So in part 1, we basically talked about the naming convention, why we call it vernal keratoconjunctivitis. We talked about the basic features, the fact that it is bilateral and recurrent and most commonly occurring in the spring and the summer, the fact that it has a definite association with hot weather, and that it primarily affects young boys in the age range of 5 to 15. We also talked about the classical clinical presentations, the fact that ocular pruritus will be present in pretty much all cases. In addition, we talked about the division of vernal keratoconjunctivitis or its classification into palpebral and limbal form on the basis of different clinical signs. The fact that the palpebral form of vernal keratoconjunctivitis is basically characterized by the presence of large papillae on the conjunctiva lining the upper eyelid, and the fact that the flat topped appearance of the large papillae gives a classic cobblestone appearance, as you can see over here. We also talked about the characteristic ropey mucoid discharge. Similarly, in the limbal form, the signs and symptoms are present around the limbus, which is the narrow area between the sclera and the cornea. So the presence of white, discrete, superficial spots on the limbus, known as Horner-Branda spots, are pathognomic for the limbal form, as you can see over here. In addition, gelatinous papillae are present along the limbus, and there's an image in Jatoi which is clearly showing this. There's also the mixed form. We also talked about the fact that keratopathy is going to be present in vernal keratoconjunctivitis, that there will be the presence of superficial epithelial keratopathy, and this will basically be a punctate keratopathy. But in addition to the punctate keratopathy, there will also be subepithelial fibrosis. Alright, there will be subepithelial fibrosis, better said to be subepithelial scarring, and there will be the formation of shield ulcers. Shield ulcer is an interesting keyword because of the punctate epithelial keratopathy. There will be the development of macro erosions in the cornea, and these macro erosions on the cornea will be covered by desiccated dehydrated mucus, forming shield ulcers. After that, there will be the development of subepithelial scarring as well as peripheral neovascularization, and all of these features of keratopathy can lead to blindness. So that is something you should be on the lookout for. So how do you diagnose this condition? There isn't any set diagnostic criteria. You basically you diagnose on the basis of epidemiology and clinical features. Epidemiologic points like the locality of the patient, the age of the patient, the gender of the patient, the presenting complaint. So if it's a young boy who belongs to a temperate climate, a very hot climate, and is presenting to you with ocular pruritus, and on examination there are giant papillae on the upper eyelid, you're going to diagnose the individual as vernal keratoconjunctivitis. What about differential? The main differential of vernal keratoconjunctivitis is atopic conjunctivitis, but the way to differentiate that is based on the fact that atopic keratoconjunctivitis is perennial, it's not seasonal, and it is not specifically associated with springtime. So that's one thing you use in order to make a differential, and there are the stuff too. For example, there is a lot of corneal scarring and neovascularization in atopic keratoconjunctivitis. So what about the treatment? The treatment of keratoconjunctivitis is pretty long term and requires frequent follow-up, and there's basically a mixture of pharmacologic and non-pharmacologic therapies. So the first thing which needs to be done is the avoidance of allergens. So this is the first thing you need to be doing. What are the first line pharmacologic therapies? Mast cell stabilizers and antihistamines, they constitute first line pharmacologic therapy. Alright, and so that's an important bit. So treatment with topical corticosteroids is done in severe cases but avoided because of the side effects. Immunotherapy can be done if the person is not responsive. Some additional medications that can be effective in some patients include non-steroidal anti-inflammatory. So mast cell stabilizers and antihistamines, they're generally given topically, and their topical application is first line pharmacologic therapy. But in some other patients, topical steroids might be used, or NSAIDs might be used, or something like acetylcysteine might be used, and as well as oral antihistamine. Oral antihistamines are quite effective in certain patients. Alright, so if the person has a severe case which is not responsive to steroid and first line pharmacologic therapy has failed, supratarsal steroid injection might be used. Alright, so this is important bit. Acetylcysteine is basically, how should I put it, it's a mucolytic. So we're done with this topic. I'm hoping this was really helpful.